everyone. So today we are going to study a very important topic, that is NSAIDs, non-steroidal anti-inflammatory drugs. These are the class of group which have analgesic, antipyretic and anti-inflammatory actions in different measures. That is, they will show the property or as painkiller, as killing of fever, and also suppression of any kind of swelling that occurs in the different measures. Now, in contrast to morphine, which is also a non-steroidal anti-inflammatory drug, they in this contrast they do not depress CNS, as we also know it is a narcotic analgesic. So in this contrast, it does not depress CNS or produce any kind of physiological dependence. We have the classification of NSAIDs. NSAIDs can be classified as non-selective COX cyclooxygenase inhibitors, also known as traditional inhibitors, in which we have different subclasses: salicylates, aspirin, propionic acid derivatives, ibuprofen, ketoprofen, naproxen, phenamate, mefenamic acid, enolic acid derivatives, piroxicam, tenoxicam, acetic acid derivatives, ketorolac, lac or endomethacin. Then we have pyrazolone derivatives, that is phenylbutazone and oxybutazone. Then in preferential cyclooxygenase 2 inhibitors, we have nimesulide, diclofenac, aceclofenac, etidolac, maxolicam, etc. Then we have another important class, that is selective COX-2 inhibitors, in which we have celecoxib, etirocoxib, parecoxib, etc. Then analgesics and antipyretics with anti-inflammatory action, important class, in which we have a very well-known common drug, paracetamol, that is acetaminophen, paraminophenol derivative. And then we have pyrazolone derivatives, that is your metamizole, propionazole, and benzoxazine derivative, that is nifopam. Then we have the mechanism of NSAIDs. All drugs included in your non-steroidal anti-inflammatory drugs possess of the same mechanism of action, that is membrane phospholipid. In the presence of enzyme phospholipase, A2 is converted into arachidonic acid, and this arachidonic or arachidonic acid leads to the activation of lipooxygenase, that is phylox, that gives leukotriene, and cyclooxygenase, that is COX-1 and COX-2, gives prostaglandin 2 and PGH2, which further leads to the formation of prostacyclin, prostaglandins, and thromboxane. Now, this cyclooxygenase or COX-1 and COX-2, these are helpful in participation in the housekeeping physiological functions, such as secretion of mucus, of protection of gastric mucosa, hemostasis, maintenance of renal function. Those produced by COX-2 lead to the inflammatory and other pathological changes. Now, during this, if we inhibit the COX, in this, the COX-1 and COX-2 are inhibited by the NSAIDs. Okay, so these are inhibited by the NSAIDs. So obviously any kind of function will not be performed as further. Then we have non-selective COX inhibitors. Now, as we know, the first drug, salicylates, aspirin, propionic acid derivatives, ibuprofen, phenamate, mefenamic acid, enolic acid derivatives, may we have piroxicam, tenoxicam. Acetic acid derivatives, may we have endomethacin and ketorolac, and pyrazolone derivatives में phenylbutazone and oxyphenylbutazone. Now we'll see the action of these non-selective COX inhibitors. So we have different actions, like analgesics, it will show plus effect, antipyretic plus, anti-inflammatory plus, renal salt water retention plus, delay in the prolongation of labor plus, aspirin sensitive asthma plus, ductus arteriosus closure unknown. Okay, so we have to just remember all this and along with these actions. Okay, as we know, arachidonic acid leads to the formation of COX-1, COX-2. COX-1 is constitutive, COX-2 is induced. It shows inhibition is undesirable, the year the inhibition is desirable. COX-1 is usually useful in performing housekeeping functions as homeostatic functions, and like your gastrin maintenance of your gastric mucosa, renal tract maintenance, platelet function, microphage differentiation, whereas a COX-2 induced, this is just the inhibition is desirable and it is used for inflammation or other pathological conditions. Now the ductus arteriosus closure. What is ductus arteriosus? So it is a blood vessels wherein which allows the blood to go around the baby's lung before birth, and soon after the infant is born, the lungs fill with the air and the ductus arteriosus is disappeared or no longer needed. So it often just closes after couple of days. Okay, so these actions like analgesic, antipyretic, anti-inflammatory, renal salt water retention, delay or prolongation of labor, you have both the action as positive response for your aspirin sensitive asthma precipitation, and for your antiplatelet aggregatory or your gastric mucosal damage you have plus minus, and for the ductus arteriosus you have plus and unknown. Then we have non-selective COX inhibitors, in which we have seen the salicylates aspirin in that inhibits the COX and decreases the platelet aggregation. Then we have the enolic acid derivatives such as piroxicam, deoxycam, analgesic, antipyretic, anti-inflammatory. Then we have pyrazolone derivatives, that is phenylbutazone and oxyphenbutazone, which is the enzyme inducers. We have phenamates, mefenamic acid, short-term analgesic. We have the last propionic acid derivatives, that is ibuprofen, non-selective COX inhibitors, and acetic acid derivatives, ketorolac, or that is inhibitor of prostaglandins, potent anti-inflammatory with mild analgesic antipyretic activity. Let's move to the next class of drug, preferential COX-2 inhibitors, in which we have nimesulide, diclofenac, acylfenac, and etidolac. This nimesulide is a NSAID which is relatively a weak inhibitor of prostaglandin synthesis and moderately a COX-2 selective. Okay, and it is used for short, long-lasting pain like sports injuries, ear, nose, throat disorders, dental surgery, low backache, dysmenorrhea, post-operative pain, osteoarthritis, fever, etc. This nimesulide is almost completely absorbed, 99% plasma bound, and extensively metabolized and excreted mainly in urine with the T half of 2 to 5 hours. Then we have diclofenac sodium. It's an analgesic, antipyretic, anti-inflammatory drug which inhibits the prostaglandin synthesis, and somewhere the antiplatelet action is not appreciable due to COX-1. And acylfenac is a moderately COX-2 selective congener of diclofenac having similar properties. Then meloxicam is again a new congener of piroxicam. Then the drug etidolac. Etidolac is the newer indolacetic NSAID which is moderately a COX-2 inhibitor with the property similar to diclofenac sodium. Selective COX-2 inhibitors, celecoxib, etirocoxib, paroxib, because of the theoretical advantage of inhibiting COX-2 without affecting COX-1, some highly selective COX-2 inhibitors have been introduced over past 2 decades. This caused the changes of the gastral mucosal damage, occurrence of peptic ulcer, bleeds clearly with the traditional NSAIDs. The traditional NSAIDs are your non-selective NSAIDs. Okay, and they do not depress the thromboxane A2 production by platelets, do not inhibit the platelet aggregation or prolonging the bleeding time. The last one, it is analgesic and antipyretics with poor anti-inflammatory action. We have the paracetamol. Recent research have shown that previously known COX-3, which found in brain and spinal, is inhibited by the paracetamol. Okay, and it has no GI side effect. Metamizole inhibits COX-3 with highly affinity compared to COX-1 and COX-2. Benzoxazine derivative, that is nifopam. The mechanism of action is unknown. Thank you.